Welcome all to the today's session. The session is about enhanced recovery in gynecology. This is from the surgical skills and postoperative module. We begin with our code master MRCOG with concept oriented clarity. Okay, so this talk is important from part 2 MRCOG as well as part 3 MRCOG point of view. For part 2, there will be one or two SBS from this particular topic, especially in the first 7 and 8 slides. You will find some information important for part 2 MRCG, but rest of the slides are important from part 3, what exactly the enhanced recovery is and how they can ask you a part of a station in which you will be given some operative procedure, and they will ask you how will you implement this enhanced recovery pertaining to these particular surgeries or something like that. Okay, so and there are many challenges, what challenges will you face, etc., and how to encounter. So this particular topic is important from part 2 as well as part 3 MRCG point of view. So what exactly the enhanced recovery in the gynecology is? So enhanced recovery pathways, these are structured evidence-based perioperative care protocols designed to improve the quality and experience of care for patients undergoing elective gynecological surgery. So those patients who are undergoing elective gynecological surgery, how to improve the quality and experience of care for patients. So this is what is the main focus. Then ERPs aim to accelerate the post-operative recovery, enabling patients to mobilize earlier and can be discharged sooner without increasing the complications or readmission rate. Okay, so it is not only the quality improvement, but most important, it should not increase the complication as well as readmission rate also. So they help to minimize physical and psychological stress by optimizing perioperative, intraoperative, and postoperative care. Okay, so these ERAS or the enhanced recovery, the action we need to take at preoperative, intraoperative, and postoperative care. Okay, so we need to have the protocols for all these steps or the phases. Okay, so ERPs promote active patient involvement in their own care, improving satisfaction, compliance, and overall outcomes. Successful ERPs require multidisciplinary teamwork, standardized pathways, patient education, and continuous audit. Okay, so one of the important component is active patient involvement. Okay, so there are certain features about these ERAs. These are highlighted. So you remember this particular thing because they can ask you some qualitative type of SBA. Okay, so these words are important, which are highlighted. Okay. So enhanced recovery pathways elements, what are the elements? So some components already we are actually using our day-to-day routine gynecological care, like pre-assessment clinics are there, antibiotic prophylaxis, thromboprophylaxis, etc. They are routinely practiced. But there are certain other components such as carbohydrate loading. Okay, then individualized goal-directed fluid therapy, especially in elderly patients, there has to be goal-directed fluid therapy. So these are little newer concepts. And pre-operative care, so it begins in the pre-operative, this enhanced recovery pathway. When it begins, it doesn't begin from the admission, but it begins from the pre-operative care. So what are the steps in the pre-operative care? The risk assessment and the optimization. Okay, so early pre-operative risk assessment that will help to identify and the optimize comorbidities that will lead to reduced complication and perioperative mortality. So if the comorbidities such as diabetes, blood pressure, etc., they are identified early in the preoperative period, and if they are taken care of, the intraoperative and postoperative morbidity and mortality will be less. Ideally, it begins in the primary care before referral. So ideally, it should begin in the primary and it should begin in the before the referral. Okay. Then there comes the role of pre-admission clinics. Okay. So before admitting the patient will attend these pre-admission clinics. The formal pre-admission clinics recommended for standardization and early optimization, facilitate patient assessment, investigation, and surgical planning. So here we will see to it that the patients are fit for the surgery. Okay, and comorbidities are taken care. Okay. Then the what else we need to do? We need to give the complete information and we need to provide the education to the patient. So provide complete verbal and written information explaining the surgery, recovery expectations, and the patient responsibilities. So that needs to be explained in the preoperative period only. Then benefits will include improved understanding of the care pathways, reduced need for postoperative analgesia, and improved hospital experience. The consent procedure specific counseling should also be done. So procedure specific details will improve preparedness and reduce anxiety. So the patient will be prepared for that procedure to undergo if there is a specific counseling at the time of consent. Okay, specialist nurses play a central role in coordinating these enhanced recovery pathways. Anticipated discharge planning, and the most important here is a discharge is planned before the admission itself. In the sense, in the counseling only, you need to tell in general, if the things go well, this is what is the tentative discharge timing. Okay, so at the time of admission only, the discharge is planned. Okay, standardized pathways allow accurate planning of the discharge dates. Patients and carers should know expected hospital stay to arrange home transport. So expected hospital stay should be informed to the patient. Okay, now coming to the perioperative. Up till now, what we have seen is a preoperative. Now coming to the perioperative care. So in perioperative care, what exactly we are supposed to see? One is admission and fasting. So when the patient should be admitted, patient should be admitted on the day of the surgery, and this reduces unnecessary bed use. Okay, hospital bed use will be reduced. Okay, then fluid fasting should be limited to 2 hours pre-anesthesia. Okay, it is safe without increasing the aspiration risk. Okay, so the fasting should be 2 hours pre-anesthesia. Then carbohydrate loading, that is complex carbohydrate drinks are permitted. Okay, so that reduces the length of the stay. This is the basically this ERAS pathway or enhanced recovery pathway. They started for the colorectal surgery first. Later on, we are using for gynecological surgeries also. Okay, so there is evidence from the colorectal surgeries that it reduces the length of the hospital stay if the carbohydrate loading is used, and it improves also the patient satisfaction. Okay, avoidance of mechanical bowel preparation. Okay, this mechanical bowel preparation, there is no benefit in elective colorectal surgery while bowel continuity is restored, and generally avoid bowel preparation in gynecological surgery due to morbidity. Okay, so when you see this particular enhanced recovery pathway, please understand what is done and what is not done. Okay, so here there is no role of the bowel preparation. Okay, and in pre-admission, they have mentioned about one is admission time on the day of the surgery, reduce fasting time up to 2 hours before anesthesia, and carbohydrate loading is permitted. Okay. Then coming to the pre-medication and prophylaxis, avoid long-acting sedative medication that will delay the mobilization of the patient. Okay. Then routinely antibiotics should be used before the incision, and VTA prophylaxis, mechanical as well as pharmacological, should be used. Okay. Then coming to the surgical techniques. Now we are intraoperatively. So one was a preoperatively. Then we have seen admission, perioperative. In the perioperative, we have seen about the admission. Okay. Then now intraoperatively. Okay. Intraoperatively, what should be the route? Minimal access surgery is preferred wherever it is feasible. Okay. If open surgery is required, incision should be as small as possible. Avoid routine drains and packs. Okay, like NGT tubes, then abdominal drains, vaginal packs should be avoided because they do not have a benefit and increase morbidity and delay mobilization. Vaginal pack usage requires departmental policy due to insufficient evidence. Then intraoperative temperature control. So prevent intraoperative hypothermia, reduces postoperative complications. Intraoperative fluid management, it should be goal-directed therapy. Okay, so goal-directed therapy using stroke volume optimization, it reduces mortality and length of the stay in colorectal surgery. It is recommended for major or high-risk surgery and high-risk patients such as elderly patients more than 80 years. Okay. Then standardization of the anesthesia. So what we have seen intraoperatively, surgical aspect, then anesthesia aspect. Okay. So especially when you are answering in the station, you should be talking on these particular lines. Okay. Then standardization of the anesthesia. Standard protocols will improve the outcome by reducing the surgical stress response, optimizing analgesia, and ensuring appropriate fluid management. Analgesia regime, multimodal approaches are used. Spinal, epidural, or regional blocks are preferred and use minimum opioids. Okay, faster return to the oral intake and improved patient satisfaction and quicker return to the work. Now coming to the post-operative period. So we have seen pre-operative, then peri-operative, and now third is a post-operative care. In post-operative care, early feeding and reduced IV fluids. Okay. So safe, early feeding is safe and beneficial. It reduces nausea and improves satisfaction, contributes to the shorter hospital stay. Okay. So next is a early mobilization. So early feeding, early mobilization. Core principle of enhanced recovery is the early mobilization. It is effective in older patients with proper education and support. The benefit is that risk of thromboembolism will be reduced, muscle loss will be reduced, and better respiratory function. Analgesia and antiemetics in the postoperative period. Again, multimodal analgesia with reduced opioid supports mobilization. So, if the opioid usage is reduced, automatically mobilization will be better. Then include antiemetics to prevent nausea and vomiting. Laxatives should be used to prevent constipation. So, in the postoperative period, there is a role of antiemetics and the laxative. Okay, and you need to avoid the opioids. Okay, so these are certain points in the pre-operative, intraoperative, and post-operative that you should remember. Okay, from SBA point of view. Then early removal of the tubes and the drains. Okay, so catheter, IV lines, vaginal packs, they should be removed as soon as possible. Okay, and it reduces the infection risk and facilitates the movement. Then voiding assessment after pelvic surgery. Risk of temporary voiding problems is there. So monitor post-void residual urine. It is safe to discharge with a catheter and arrange trial without catheter as on OPD basis or outpatient. Okay, if it is a prolonged catheterization, then you can discharge the patient with catheter and arrange in follow-up, that is trial without catheter can be done on a OPD basis. Okay. Then next is a discharge plan. Remember, in ERAS, discharge is a criteria based. Okay, so the once the criteria for the discharge are fulfilled, then discharge can be given, and nurse-led discharge is possible once the patient is mobilizing independently, eating and drinking, passing flatus, pain is controlled with oral analgesia. Then at the time of discharge, provide written instructions including emergency contact numbers, expected recovery timeline, guidance on wound care, mobility, diet, etc., and warning signs. Okay, or any red flag symptoms should be explained. Okay, which requires medical attention. Okay, and they should be told about the follow-up model. Okay, generally 24 to 48 hours there will be telephonic inquiry by the nursing staff, and patient trigger follow-up. For that, you need to give the contact number. Okay, patient will contact the ward or the helpline for any concern. Okay, so this is what we have seen: pre-operative, peri-operative, post-operative, and the discharge. So in the pre-operative, there is a role of pre-assessment clinic, the patient education, the discharge is planned in the pre-operative period itself, and optimization of the comorbidities. So these are the steps which are taken in the pre-operative period. Then coming to the peri-operative, it will have on the day of admission, fasting, then intraoperative the surgery and anesthesia aspect. Okay, so day of surgery admission, 2-hour fluid fasting, avoid bowel preparation, prophylactic antibiotics, thromboembolism prophylaxis or VT prophylaxis, minimal access surgery, that is the root of the operation, then avoid drains, maintain normothermia and goal-directed fluid therapy. So these are perioperative. Then in the postoperative period, early feeding, minimal IV fluids, multimodal analgesia, early mobilization, early removal of catheters and drain, and post-vital residual monitoring. Okay. Then discharge is a criteria-based discharge. Written instructions should be given, and telephonic follow-up or the patient-triggered follow-up. So these are the things which are pertaining to the enhanced recovery protocol. Okay, so these are few things, especially from SBA point of view, certain questions can be asked from this. Okay, now this is same is shown here in a flow chart. Okay, there is a referral from the primary care. So before referral, only certain things which are which needs to be taken care, like optimize pre-operative hemoglobin level, manage pre-existing comorbidities such as diabetes, etc. So this has to be managed at referral level or the before referral only. Okay, and pre-operatively what we are supposed to see, whether optimize health and the medical condition, we need to confirm whether these things are there or not. Okay, then the informed decision making, pre-operatively health and risk assessment, Patient information and expectations should be managed. So proper counseling regarding the procedure, hospital stay, etc. should be given. Then discharge is planned. Uh, Planned date is agreed with the patient, and pre-operative therapy and instruction as appropriate. So this is what is done in the pre-operative period. Now coming to the admission, this also we have seen admission is on the same day. Optimize fluid hydration, carbohydrate loading, then reduced starvation, and no or reduced oral bowel preparation. Okay, so bowel preparation is either not required or should be reduced. Okay, intraoperatively, we have seen minimal invasive surgery, use of transverse incision if it is a open surgery, then no NGT, use of regional blocks, then epidural management, optimize fluid management, and individualize goal-directed fluid therapy. Post-operative period, planned mobilization or early mobilization, rapid hydration and nourishment, appropriate IV therapy, remove drains, NGT catheters as early as possible, and you will monitor the post-void residual volume. Regular oral analgesia, paracetamol and NSAIDs can be used. Avoidance of systemic opiate-based analgesia wherever possible or administered topically. Okay. So this is done in the post-operative. And follow-up, in the follow-up, there are two things. One is a discharge is a criteria based, and for follow-up, it can be 24 to 48-hour telephonic follow-up or patient triggered follow-up. For that, you need to give emergency contact number, etc. So this is all about enhanced recovery. Okay, from here onwards, there are certain slides which are mainly important from part 3 MRCOG point of view, but I'll read this particular thing out. Okay, so for patient involvement, quality and cost implementation. So these are the peculiarities about this enhanced recovery protocol. So there has to be patient involvement. It has got a benefit with respect to the quality and cost and how to implement all these care pathways. Okay, so what is most important is a patient involvement. That is central philosophy of this ERAS. Okay, so enhanced recovery is built on active patient participation rather than passive sick role. Okay, which is seen in traditional care. Involvement of the patient is directly from not only from the decision point of view, but it will extend into throughout the surgery and discharge, and it emphasizes partnership with the clinician. So there is a lot of role about the patient involvement. Okay, there is a early information and psychological preparation that is also a part of patient involvement. Okay, so we have discussed in early or as a pre-assessment clinic or before admission only, whatever the clinic attendance is there at that time, you need to give the complete information. So accurate, consistent information starting from primary care referral aligns patient expectations with the clinical team. There is a shared decision making that helps women assess the necessity of the surgery, encourages involvement in choices about the treatment and discharge timing, reduces fear, misconceptions, and outdated beliefs based on others' experiences. And how it can be done? There are my role and responsibilities in helping to improve my recovery. So there are certain leaflets. Okay, so it is patient's role and patient's responsibilities. If you give certain information in form of leaflets and all, that can be one of the tool. Then national patient information leaflets promoting active involvement, then encourages responsibility, motivation, and engagement, improved outcomes and satisfaction. So all this will lead to the improved outcomes and satisfaction. Okay, so patient involvement is one of the important. Now we will discuss about the quality and cost, and then what are the challenges in the implementation. Okay, so apart from this, there has to be consistent messaging. So all members of the managing the team should deliver the same information at every stage. So some trusts use innovative educational tools like patient information evenings or educational DVDs. So in the pre-operative period or the post-operative period, you can use this particular, there can be special gathering of the patient, such as patient information evenings are arranged. Okay, then access to the further support. Patients should know whom to contact for queries, clear pathways for advice, enhance confidence and safety. Importance of patient feedback. Patient feedback is essential for audit and quality improvements, and that can be either structured questionnaires, interviews, or informal patient parties. Okay, so these are the ways by which you can ask the feedback from the patient. So next part is a quality and cost. Okay, so enhanced recovery will lead to the faster recovery, shorter hospital stay, and that will lead to good quality care. It is comparable or lower complication rates versus conventional pathways. There is no increase in the readmission rates and the postoperative primary care workload. Okay, so most important is the this particular readmission rate should be less and the complication rate should also be less. Then there is a patient as well as staff satisfaction. Okay, this patient satisfaction is because of the reduced pain, earlier mobility, more control over recovery, improved nurse satisfaction due to predictable pathways. Okay, so you will have everything very protocol wise, so the nursing staff will also have a satisfaction and improved patient outcome also. Okay, so evidence shows the improved quality of life post surgery with enhanced recovery. And there is an economic impact. Implementation cost vary based on existing infrastructure, so there will be saving from the shorter hospital stay, more efficient bed uses, and increase uh, so minimal invasive surgery, actually is minimal invasive surgery. The key principle for enhanced recovery is this minimal invasive surgery. But they have done the survey in 2010 and 11. They have found out in NHS almost 79% of the benign hysterectomies were abdominal. Okay, that is a hospital episode statistics which show that most of the hysterectomies are still abdominal. Okay, so if you see other countries, European countries, this rate of abdominal surgeries is less. So there is a further scope in implementation of these ERAS pathways. Okay. Now, what are the challenges in implementation of enhanced recovery pathways? There are many challenges. Okay. Enhanced recovery challenges, traditional practices, okay. Resistance may, there can be resistance by the staff itself. Okay, this may be because of the concepts are new. Okay, so unfamiliar concepts such as carbohydrate loading, limited laparoscopic skills, requires behavioral and cultural change. Okay, so these are the challenges in implementation. Then not only that, stakeholders engagement. So all the stakeholders, okay, like successful enhanced recovery program requires commitment from all sectors like primary care, secondary care, social care. We have seen that flow chart at all level. This protocol should work. Hospital, clinical, and management teams should also have coordination. And sustainability will depend on organization-wide support. Okay, so core implementation team will include surgeon, anesthetist, then specialist nurses, managers, etc. So this is actually the core implementation team. Then education and local ownership. Locally tailored ER pathways and protocol must be developed for ownership. Okay, continuous education ensures that awareness of pathway changes, then understanding of each professional's roles and commitment to consistent care delivery. So education and local ownership. So whatever the commonly used surgeries are there, so you have to tailor your protocol pertaining to your area. Okay, and there has to be continuous audit and data collection. Okay, so these are the important things and the challenges in implementation of the uh, enhanced recovery program. So what we have seen: patient involvement, clinical benefits, cost impact. Okay, so patient involvement is in form of early education, shared decision making, consistent messaging, and feedback driven improvement. Then length of stay is reduced. That is the clinical benefit. Complications are less. Improved satisfaction, stable readmission rates. Okay, the cost, because of the number of beds are usage is reduced, increase activity capacity, and variable implementation cost. Okay, and implementation also we have seen there has to be inputs from all sectors. Okay, so conclusion is that enhanced recovery in gynecology. So enhanced recovery leads to higher patient satisfaction by improving overall experience of care. Enhanced recovery protocol result in standardized, consistent care with less variation between clinicians and hospitals. ER contributes to shorter length of hospital stay, enabling faster return to normal activity, and it reduces post-operative complications and hospital readmissions. And these protocols should be implemented throughout the NHS. Okay, so that finishes the topic of enhanced recovery. Thank you.